Good afternoon or evening and welcome. Kensington Senior Living has 7 unique communities, 4 located in Virginia, Maryland, and New York, and 3 sister communities located in California. Kensington is truly privileged to support care partners and professionals coast to coast, and we just opened a brand new community in Bethesda. Kensington focuses on relationship-based care, care built on the foundation of our promise to love and care for your family as we do our own. It is programs such as the one you are attending now that are so important for those of us walking through a caregiving journey, and to hear from expert professionals on keeping us current with the latest advances in care, management, and treatment of conditions that affect seniors and their families. I was first introduced to the Kensington family 10 years ago, and my father was a resident in Northern California for over 7 years. Today, you're in for a special opportunity to hear from the world's top neurologists about Alzheimer's and brain disease. November is National Alzheimer's Awareness Month, and we are excited you are joining us. Everyone that is registered for today's event will receive a copy of the webinar to share with friends and family. Please share this unbelievable knowledge with your friends and family. And please also know to utilize the Q&A function to submit questions to our panel. It is now that I would love to welcome our guests, and I'm going to start with Travis. Travis, can you join us, please?
I'm here. Hello, hello.
Hello, Dr. Travis Urban. How are you today?
Good. How are you, Susan?
Good. Thank you again for helping me with our script and putting the questions in a very digestible format. I really appreciate it.
Of course.
And tell us a little bit about yourself.
Great. So my name is Dr. Travis Urban. I am a cognitive neurologist, so a neurologist who specializes in disorders of cognition. I'm also the associate medical director at the Dolby Brain Health Center, which is a large memory care clinic based in San Francisco, part of CPMC and Sutter Health. And so I've been here 3-ish years now. And I practice in San Francisco and Nevada, California.
I also have to say that he has 3 children and that he lives very close to his sister-in-law.
I live next door to my sister-in-law.
I just think that's
Uh,
so cool that your kids run back and forth. I just love that.
yeah, it's a party. It's a party. Oh
It's a
yeah.
dream. It's a dream. It's built-in babysitting, actually.
Definitely. Yes. And sorry, my voice is kind of going, so I'll do my best. But if I sound a little bit like Mickey Mouse, I apologize.
Probably because you were Mickey Mouse for Halloween. Um,
Yeah.
Irina, can you join us, please?
Hi, everyone. It is a joy to be here. My name is Irina Schuyler Scott. I'm a cognitive neurologist at Stanford, and I'm also topic chair for aging and dementia for the American Academy of Neurology. And my interests, first of all, my clinic is dedicated to caring for patients with dementia. And my interests are twofold. One, I help run clinical trials for patients with Alzheimer's disease here at Stanford. And I'm also very interested in preventable lifestyle factors and how they affect cognition for patients and how they prevent dementia.
And I have to give a plug to Stanford. My father, who passed away from Alzheimer's in 2021, was diagnosed and treated, and also went through the young blood plasma with Dr. Sharon Shaw. And I cannot say enough wonderful things about the team at Stanford. So thank you all for what you do. And
Thanks
next,
for sharing your story, Susan.
oh, well, you guys are just the best. I mean, you have as much heart as you do head, if you know what I mean. You're as smart as you are a big heart. So, and Dr. Golnaz, can you join us, please? Thank you.
Hello, everyone. I'm Golnaz Yadullahi Khalis. I'm working at Cedars. I'm a behavioral neurologist as well. I joined Cedars about 2 years ago, so not too long ago. And before that, I was actually up north in Northern California. And my interests are actually on phase processing and trying to find out new biomarkers, diagnostic biomarkers, to be able to differentiate between the different neurodegenerative disorders.
So you would differentiate by your facial expression?
Uh, face processing, like the differentiation between face recognition and face perception. Yeah,
Oh.
that's the hope.
Oh, goodness. Well, that's so nice, because how many types of dementia are there? Like 142? There's some amazing number of, and it's sometimes that's confusing, but we'll delve into that in 1 second. And Layla, can you join us, please? Thank you.
Hi, I'm Layla Prant. I'm an assistant clinical professor at UCLA, and I'm also part of the caregiving clinical trial team here at UCLA.
Thank you. So we have 2 Northern Cal and 2 Southern Cal. We got California covered. Let's go ahead and start with a discussion, a roundtable conversation about diagnosis. And Travis, I'm going to start this. There's a whole bunch of questions that came in at registration, but I want to remind the audience to utilize the Q&A in the function of the webinar as well. About diagnosis. So what is the approach, or what is an approach that you feel is working to diagnosing Alzheimer's? And just what we were talking about, how can you differentiate that from a different type of dementia? Travis, I'll start with you, and ladies, please join in. Go ahead, Travis.
Yes. Yeah, please jump in with all the things I probably forget to say. But I think starting from a very beginning, I think the very basic thing that all of us try to do first in clinic, in our very specialized clinics for cognition, is try to answer this question of, is the cognitive changes I feel like I have, are those just due to normal cognitive aging, or is this due to something more, something that could be progressive or a dementia? And that's really the first basic question we're all trying to answer, right? All of our brains change as we age. It's true. Like, we don't have the same mental processing as we do when we're in our 70s or 80s as we do in our 30s. So it's answering that first question, is sort of our first step in clinic. And I want to also back up and just say, what are even the signs that I should be looking out for, either in myself or in my loved one, that could make me concerned about a very early stage Alzheimer's disease? I think this is sort of where it starts, right? What are the things I'm watching out for or trying to see? And just to say it and have it out there, one of the most just common age-related cognitive symptoms we hear about is this word finding difficulty. And I just can't remember that like actor that was in the movie, and it doesn't like come as quickly as it necessarily did when we were younger. And that's a very common thing that can happen. And it often isn't a cause for worry. For me, most often when we're talking about Alzheimer's disease, we're often focused on memory, and really that short-term memory, sort of forgetting what was just discussed in a conversation or forgetting what we did yesterday, things like starting to repeat the same question over and over again, or telling the same stories sort of within a short time window. These are all very sort of early signs that maybe the short-term memory centers aren't working as well. And generally speaking, when that's happening, I could it be normal aging? Sure, but I tend to start getting more worried that there's something affecting the short-term memory centers. And those sort of repetition, like recent forgetting of things that just happened, those are more reasons to start to be concerned. I'll also say that sometimes with Alzheimer's disease, like, it can start really subtly, and it's often really hard. And if you feel like you're different or changing, or if you feel like your loved one is different or changing, I mean, that your intuition and that sense it should really be your North Star. Because how do we get these evaluations? We oftentimes will start with bringing up memory concerns to our primary care, and we say, I think I have memory trouble, or my loved one has memory trouble. We start there. They may do some tests in the primary care's office. And those tests, every test is imperfect, and if in the primary care they're saying, oh, you're fine, like, don't worry about it, but you still feel something's wrong, the next step is sort of to push to see a neurologist, and have them do a more thorough cognitive evaluation with you, which we can talk about if need be what that looks like, and really just using your intuition to go from there. But that's, I think, just a crude sense of what we're looking out for, like making sure you're always paying attention to your intuition, starting with your primary care. And then if you don't feel like they're addressing it appropriately, then really going on and asking for a neurologist as the next step. But I've said a lot and there's more to say, but other thoughts from the group?
Can I just jump in for a second? So I agree with everything that Travis has laid out. So once we've made that determination that this may not just be normal aging, and this is more than we would expect based on aging by itself, I also just wanted to underscore that dementia is an umbrella term, and there are many different potential causes of dementia. So when patients come in for evaluation, in addition to determining whether or not they in fact have dementia, we're trying to determine what dementia type they may have. And that's why we do a comprehensive evaluation where we ask many detailed questions about the nature of their symptoms and do quite a bit of detailed testing on their cognition with bedside cognitive testing.
Can I ask a question? So the dementia umbrella, there's a lot of things that fall under there, including Parkinson's, like the #1 neurological disease now, I guess, and Lewy body. How does MCI, there's a lot of talk right now about mild cognitive impairment. How does that fall under the dementia umbrella? And how does that lead, or does it lead to a dementia diagnosis? Can someone take a stab at that?
I can start and then others can join in. So MCI is an at-risk stage for dementia. When we say that somebody has MCI or mild cognitive impairment, it means that either they or people around them have noticed changes in their cognition. And then when we test them, when we do various forms of cognitive testing, we're noticing more impairment than we would expect just based on their age by itself. But in contrast to dementia, with MCI, people are generally still independent. So they're still able to do their basic tasks and errands. They're able to manage their own medications and finances and appointments, so forth. And so by the time they progress to dementia, they lose that independence and are more reliant on others. And so the risk of progression from MCI to dementia varies a little bit by dementia type. But if you take someone who comes in with MCI, then I would say the risk of progression to dementia is about 10% per year.
Yeah. And just to tag on that, with MCI and dementia, like Dr. Schuyler Scott is saying, those words are really just talking about stage, just level of impairment. They're words that are on a continuum where in the beginning we say, oh, I'm just, I feel like I have subjective changes. I feel like something's wrong, but my testing seems fine. And then we start seeing things on the testing, but then in our day-to-day, we're still getting by okay. That's the MCI, where it's objective changes, but nothing impacting function or day-to-day. And then dementia, again, umbrella word, non-specific. There are many different kinds of dementia, but the word dementia in our medical context, all it really means is that it's a level and severity of decline. It's severe enough that it's starting to impact function. And then kind of within that, as it impacts more activities of daily living, more day-to-day function, it's sort of a mild dementia, then a moderate, then a severe dementia. But these words, MCI, dementia, it gets a little confusing sometimes, but they're all just words that are talking about severity of symptoms, basically. And there's different causes of dementia. And that's sort of one of the questions in the Q&A, but what's Parkinson's, Alzheimer's, Lewy body, right? Like we're saying, dementia is just a severity. It's just cognitive change that's impacting function. And then Alzheimer's disease, Lewy body disease, Parkinson's disease, dementia, these are all different causes of. You could also think about a big stroke can cause someone to have dementia, or an encephalitis, or any number of things that impacts cognition, that's then starting to affect function. And I'll say the words Alzheimer's disease and dementia in day-to-day sort of parlance often get kind of confused and used sort of interchangeably. In our world, they refer to different things. You know, dementia severity, Alzheimer's is a specific biology, but Alzheimer's disease is just by far and away the most common age-related biological cause of dementia. So that's sort of why they get interchanged, but they refer to different things. And all these different diseases, it's just different. Oftentimes, it's these different proteins clumping up in the brain that are these different diseases. So Alzheimer's disease is a specific biology of these amyloid plaques and tau tangles clumping up in the brain. Lewy body disease, it's just a different clump, this thing called alpha-synuclein that's clumping up in the brain and tends to cause kind of different symptoms than Alzheimer's disease. And there's other rarer things, frontotemporal dementia and prion disease. And again, these are all different clumps by and large that are clumping up and then causing symptoms and problems.
I want to add something to the Alzheimer's. I agree with Travis and Irina about like the stages of the dementia and then also the causes for that. So one thing about Alzheimer's disease, although we talk about like short-term memory as the most common presentation of Alzheimer's disease, when Alzheimer's presents at an earlier age, like which we call early onset Alzheimer's, especially like below age 65, and then the presentation might kind of like differ from like the late onset Alzheimer's disease, and that's what makes it like a bit confusing to diagnose, and especially for the like the caregivers like at those stages or like at that age, because a lot of times those symptoms can look like someone who's getting older, just like old age type symptoms, especially the executive dysfunction, like having trouble with like organization, like things like going to a room, forgetting why you went there for type of thing, or you're talking about something, you forget what you were talking about. But there are all different presentations, like even for Lewy body dementia, like the presentation can be different among different patients. So that's what makes it confusing or like difficult for even the providers to diagnose.
That's so interesting. And actually, you guys answered a question from Barbara. So Barbara, I hope you got your question answered. But I just have a quick question. Is MCI a precursor to all the different types of dementia? So like, could I have MCI and it could lead to Parkinson's or Lewy body or vascular or one of those things?
Yes, MCI can be a precursor stage to advancing to dementia.
And then a question came in. They live in independent living in a senior community, and they give them tests every 6 months. The MOCA test, I think it is, where there's those 30 questions and remember these 5 things. Is there any additional testing that, besides that questionnaire, that you guys have come up with or that there is available?
Right. So the MOCA is sort of the MOCA test is the best. Well, it's sort of the workhorse that we use. It's pretty good as a screener because it covers a lot of different areas of cognitive functioning. There's the 5 words that are looking at your memory, but there's also, you know, visuospatial function when you draw a clock, often the cube, and there's more executive tasks like sustaining your attention and doing some mental math. So it covers a lot of different areas and gives us a lot of good information quickly. That said, I mean, it's only like a 10-minute test. It's not perfect. If we need more in-depth testing, there is a kind of neurological testing called neuropsychological testing, which is basically just the MOCA on steroids. It's 3 hours of similar kinds of tests that again test different domains and then compare you to other people of your age and education level. Because it can be hard. I mean, we don't want to compare you to other 30-year-olds. We didn't see like, are you scoring about where you should for a well-educated, 60 or 70-year-old, right? And that's the whole point of the neuropsych testing. It's much more detailed. It gives us a much clearer picture of, is there actually a cognitive problem going on beyond age? And if the MoCA test, even if someone is scoring like perfect on the MoCA test, there could still be things that come up on the neuropsych testing. And so it's always the next step is the better, it is the best cognitive test. It's just long. It's at least 3 hours. It's a neuropsychologist who administers it, not a MD, not a physician. And the physician will usually refer you to a local neuropsychologist in your area to do the tests. They're all the same tests. The neuropsychologists at UCSF, at Stanford, at Sutter, we're all doing these same very standardized tests. So you can get it wherever you are, so long as there's a neuropsychologist not far from you. If your physician feels that, we're not getting good enough data from the beds, the testing we do in the office, and we need something more sensitive. Yeah.
And Layla, if you're going to go down the road that you need some additional diagnostic testing for suspected Alzheimer's, can you touch on a little bit about additional exams, labs, imaging, cognitive tests, MRI, whatever you would do? How would you progress on that?
To help determine that, thank you for the question. To help determine that, usually I find it very important to ask questions about the symptoms early on that the patient had at the beginning, as well as how it's progressed over time to better determine what type of additional testing I'm going to do. So when a patient comes in, I'll ask the patient and the family member, if the family member is available, or try to contact the family member. And I'll go into as much detail as I can within the time frame that I have. Sometimes it's nice that specialists get a little bit more time than a general neurologist to go over those questions with patients. So I'll try to get a good detailed history about the memory difficulties they're having, how it's progressed over time. Has it been a slow progression? Is it fast? Different types of ways that it progresses can help to determine the etiology, and then what type of imaging modality or blood test that I'll perform. I'll ask about language, if there's been any language difficulties. I'll ask about their ability to read and to write, and if that's been affected. I'll ask about how they're able to see things in space, whether they're able to find things that are in front of them. I'll ask about their ability to make judgments, whether that's been impaired, are they falling for scams. I'll ask about hallucinations and how their mood is, and if needed, further evaluate mood and how it's being treated. Hearing from both the patient and the family members, getting a good history about their past medical history. Do they have any autoimmune diseases? Do they have chronic illnesses, as is mentioned in the questions? And trying to see, are there other contributing factors? Do they have vascular risk factors that need to be addressed and evaluated in conjunction either with their primary care physician or how I can manage? And asking about a detail of their psychiatric history, their medications. Can medications be contributing? And that would help to determine what type of additional labs that I would need to evaluate for. I might evaluate for inflammatory markers, or send them back to the primary physician to evaluate for inflammatory markers, or check for vitamin deficiencies if needed. If there's a history of alcohol use, I focus on certain vitamins that might be associated with alcohol use, how their diet is, if it's been fluctuating, the weight's been fluctuating, are they not eating well? And I'll ask about sleep. Is there contribution from poor sleep, or sleep apnea, or restless leg, or REM sleep behavior disorder, which might be a clue to a different type of diagnosis other than Alzheimer's disease. And when I get all that information, that will help me to determine not only the blood biomarkers, but also the imaging modality. So usually for patients that have concern for either a cognitive or behavioral change, I'll end up getting an MRI to evaluate for any vascular risk factors, atrophy, shrinkage in the brain, or anything big that might be contributing. And then I'll consider doing if there's a concern for Alzheimer's disease, blood-based biomarkers, and then imaging modalities. I tend to hold off on CSF analysis right now because there's so many plasma markers, unless there's a concern for another etiology where I would need to do and look for other things that might be contributing, like prion disease if it's a rapidly progressive dementia, or autoimmune contributions, and if needed, neuropsych testing.
It sounds like from all that information that you have now gathered, because a question came in, are you going to be able to say Alzheimer's, Parkinson's, vascular, or Lewy body, and continue your testing from there? Will that information give you enough to maybe make a determination on the type of dementia?
After a further workup, yeah, probably. Yeah.
And can we talk a little bit about biomarkers? That's such a hot topic right now. Does anyone want to start with that, about the different biomarkers? Because questions came in about genetics as well.
I was just going to say that this is actually a really exciting time for diagnosis, in that, these new tests are emerging that that we didn't have access to before. And so even in the last 5 years, the tools we have to make a diagnosis of Alzheimer's disease or dementia with Lewy bodies has changed and evolved. So we're really fortunate to have these new tools. So for example, in the case of Alzheimer's disease, if a patient is potentially eligible for and interested in these new therapies called anti-amyloid antibodies, then we'll often do a test to confirm that they have buildup of this amyloid protein. And so we might either do an amyloid PET scan, or we might do a lumbar puncture to confirm that. But in addition, we have these new blood tests, which are still evolving. I think, there have already been 2 that are FDA approved. There are others that we use there are others that are coming out that have been really helpful, because just with a simple blood test, we can get a lot of information. And the same thing with dementia with Lewy bodies. Now you can do a skin biopsy or a lumbar puncture and get information about that protein that Travis mentioned, alpha-synuclein. And so things are really changing, really evolving, and there are a lot of new tools that are emerging to help us with patient care.
There is so much more. I'm so encouraged from when my dad was diagnosed in 2013. I mean, I am just excited as a Alzheimer's family member, and my mother had Parkinson's. So I'll be seeing one of you soon. Prognosis. Gulnaz, can we start with prognosis, about expectation, disease progression? Like, what do we know? And then we'll talk about prognosis, and then lifestyle, and we'll end with treatment. Go ahead, Gulnaz.
Absolutely. So in terms of prognosis, I think that's a question that we a lot of times get in the clinic. Like, a lot of family members would like to know how disease progresses, how fast it progresses, and what to expect in the future. My answer to that question is always, it is very unpredictable. It's very hard for us to say exactly when someone is going to go from the MCI stage to the dementia stage. It varies a lot in between different patients, depending on their past experiences. Let's say if someone had high level of education, had very good cognitive reserve, or has very good cognitive reserve, so they are going to progress much slower compared to someone who, for example, has a lot of vascular risk factors, for example, who's still drinking, for example, heavily, things like that. So a lot of different factors influence the rate of progression, even from one stage to the other, and in general, in terms of the lifespan in general. And in terms of one thing that we can always discuss about is what to expect next, depending on which clinical syndrome we're talking about. So, for example, if someone comes in with the typical Alzheimer's presentation, meaning short-term memory loss, repeating themselves. So things that you would expect to happen in the future would be some other degenerative disorders, is that the other cognitive domains are going to be affected as the disease progresses. So at the very beginning of the disease, patients might just have memory problems, but as the disease gets worse, then they might have trouble with a visual spatial dysfunction, for example, with driving as an example, or they might develop some problems with their language, or like they might have some word finding difficulties. And things that we always talk about are like falls, to make sure that if someone has difficulty walking, they start like physical therapy as soon as possible, because like having a fall, especially if it causes like any fractures or head trauma or like bleeding in the head, that could definitely make things a lot, like cognition, a lot worse. Other things that people should be careful about would be any swallowing difficulties. So if someone develops any like coughing or choking while eating, then we always recommend that they let us know if that happens, for us to do a swallowing evaluation. And the other thing would be an infection. Any types of infection can make cognition worse. It could be a transient thing, but then it could be like a huge change for the family members, especially like with people getting very delirious. And when they have even a small infection, it could be a urinary tract infection, it could be like a flu, a simple flu. So these are the things that I always discuss with the family members, but then in general to talk about when like things are going to change, and like is it going to change in a year, is it going to happen like within 2 years, 3 years? It's difficult to predict that. And I think it has some implications for the treatments as well, because now with the newer treatments, we try to put patients on these medications at the very early stages of the disease. So that's why and a lot of times, like, or sometimes family members or the patients would like to think more about them. I always tell them, well, I mean, it's not time sensitive in a sense that you should go on it like tomorrow, but then again, because they are only helpful, at least as far as we know, at the early stages of a disease, then and it's hard to predict when the decline is going to happen, so it's better to act fast.
You know, it sounds like these comorbidities, the diabetes, hypertension, obesity, sleep disorders, all impact the progression of any type of dementia. Is that a solid statement?
Yeah, absolutely. Even like we know diabetes can cause, besides the fact that they can cause some vascular changes in the brain, having them by themselves can also affect cognition. And they can also affect other things. For example, if someone has vascular risk factors, that can cause neuropathy. And neuropathy can put patients at risk of having falls, for example, or like sleep apnea, if it's untreated, that by itself can cause some cognitive dysfunction.
Anybody want to add anything to the progression of the disease? And we're going to touch on palliative and hospice care at the end, but I want to get to the bunch of questions are coming in about lifestyle. So Irina, I'm going to start with you about lifestyle prevention. And I think that's how I can introduce the topic, because I think you'll take it from here. And then please, the rest of the panel, please chime in.
Yeah, you know me too well, Susan. I'll just launch into my spiel. So last year in 2024, the Lancet Commission published a report indicating that there are what we call 14 risk factors that can prevent up to 45% of dementias. And there's a lot that's not within our control, our age, our genetics, although they are actually trying to change people's genes, but that's a conversation for another day. But there are things that are within our control. And so, a lot of the things on that list are what you might expect, things like alcohol consumption or cholesterol levels. But, there are societal issues on that list, like education, things like hearing loss, depression, whether you've had traumatic brain injury, your degree of physical activity, diabetes, smoking. I'm just going to read through the list because I want you to think about how you're doing with this list in your own capacity. So high blood pressure, elevated weight levels. I think I mentioned alcohol, social isolation, air pollution, visual loss. So those are the 14 where they've said there's an evidence base for these risk factors. There have been studies that have showed a clear relationship between those factors and dementia risk. But the other thing that I wanted to bring up, and this is hot off the presses, is the results of the US Pointer trial, which were just revealed this year. And so the idea is looking at what we call multimodal intervention. So if you stack all the interventions together, if you have 2,000 people who are in a clinical trial, 1,000 people in each group, and you have what we call a structured intervention. So they've signed up for an exercise course. They're signed up for a group where they're together with lots of people. They get all their lab work done to see what their cholesterol levels are. They get their vitals to see what their blood pressures are, and they get counseling on that. And then they sign up for a cognitive training, brain training course. And so everything's structured and given to them on a platter, and here you go. But it's multimodal, what I call the kitchen sink approach. So everything all at once. So that was one group. And the other group looked at education. So you tell people, oh, socialization is good for you, doing cognitively engaging activity is good for you, but it wasn't structured in the same way. What they found was that the structured approach was better when they measured global cognitive scores. So they took people a giant battery of tests across different cognitive domains, and when they took that composite score, people seemed to do better over a 2-year period if they were doing this structured intervention versus the less structured intervention. But interestingly, even the people who just got educated about what's good for their brain also did better than we would otherwise expect. So they both improved. And so I think there are a couple of take-home messages. One is that if you have the time and wherewithal to do multiple activities that are good for your brain health at the same time, the kitchen sink approach, it may be that the sum of the parts is better than any of the individual parts. But secondly, if you can sign yourself up for things, so if you sign yourself up for an exercise class or sign yourself up for a program where you make sure that you're eating healthy food, then to the extent that you can structure that in your life and schedule it in your life, that seems to be helpful. And the third piece is an accountability piece, because in that structured intervention, these people were in a group, they were meeting with a team leader, they were all updating each other on their status and how they were doing in terms of their brain health. And I think that accountability piece has a lot to do with how successful they were with their brain health. But this was a major study. It cost tens of millions of dollars to do, but I think we're really pleased that we have this randomized controlled clinical trial, our highest level of evidence that we can now point to and say, yes, this really worked. We studied it and it's helpful for people.
Does anyone want to comment on the Dean Ornish study that was started with heart and now is going to head?
So I think we have to, we have different studies that have different levels of evidence and different levels of confidence. And, as I mentioned, those big trials where you can have a lot of people who are randomized, where the intervention is blinded to the extent possible, where you have a placebo control. So, we really rely on those high quality studies to make our recommendations to patients and families. And I think that occasionally there are studies that don't meet all of those metrics, and then we tend to take them with a grain of salt.
But we do know the U.S. Pointer results talked about dementia, but we also really know, I think we'll all agree, that what is good for your heart is good for your head and vice versa. So those lifestyle factors we're talking about is probably good for overall health, not just your head.
That's absolutely the case. There are a lot of things that have overlap for heart and head. So for example, you've heard people mention vascular risk factors. So that refers to blood pressure levels, cholesterol levels, how well someone's diabetes is controlled, whether they're a smoker or not, whether they exercise or not, whether they're adhering to what we call a Mediterranean diet or not. And all of those things impact both the heart and the brain, which is great.
And
Two birds with one stone.
There was a question that came in, these structured programs. How do I find those?
I have a couple, just to shout out to a couple of programs that have been helpful. OPICA is one of the programs that's locally, but they also have an online group. They have online courses, either for physical activity as well as mental stimulating activities, as well as the Brain Exercise Initiative. You can search brainexerciseinitiative.com. It's founded by a UCLA medical student, Harvard law student, whose grandmother was afflicted by Alzheimer's disease, and she has spread a group that has gone across the nation with 80 chapters across the country, where students do brain exercises with individuals with cognitive impairment, and they can do it for about 20 or 30 minutes, these exercises. So you should check out her website.
We'll send that as a follow-up email to everybody. Opeka is a great friend of mine. I love working with them, and they have just so many resources that are available to the community. So thank you for mentioning that. Does anyone else have anything that they want to add to lifestyle? We're good? Let's go right on to treatment, though, because we don't want to forget about treatment. I'll start with Golnaz. What type of pharmacological treatments are available, and who would benefit the most? Can you talk a little bit about, before we go into trials and human trials, and you guys all have these great programs that we're working on, what about just a pill? Any pills out there to help?
So when we talk about treatments, we need to differentiate between the treatments that are symptomatic, meaning like they are helpful to manage some symptoms. It could be mood symptoms. It could be like psychotic symptoms, like delusions, hallucinations, like sleep problems, like if someone has insomnia or like having trouble sleeping, and medications that can help cognition, but not necessarily slowing down the progression of the disease. And there are treatments that are what we call disease modifying, meaning they are helping to slow down the progression of the disease. So to talk about the symptomatic treatments, we do have two pills, and they come in different forms as well. They can be patches as well. If you're more, it's more convenient for some people to put the patches on. But one is called Aricept or donepezil, and the other medication is Namenda or memantine. Although based off their labels, they should be started at the dementia stage. We tend to start them at like earlier stages as well. A lot of times I myself prescribe them for people at like MCI stage of the disease. The hope is that these medications help with cognition. The example I give patients is that like you have a headache, you decide whether you want to take a pain pill for it or not. There was this study that was done many years ago, like on Aricept, when they were trying to come up with Aricept. And they showed that Aricept can actually slow down the progression of the disease. But the problem with that trial was that it was a long time ago when we did not have biomarkers to diagnose Alzheimer's disease or to know exactly if the patients who got treated with this medication actually had Alzheimer's disease. So it is possible that some of the patients who actually improved with this medication did not even have a degenerative disorder. So, but these medications are kind of helpful with like different types of dementia syndrome. So it's not only for Alzheimer's, it can be prescribed. Actually, it's more helpful for patients with Lewy body dementia, especially Aricept. But there are differences in terms of their side effect profiles, and then like the frequency of the dosages. Like Aricept is like once a day, memantine is like twice a day. And then if you are going to talk about like other symptomatic treatments, like we do have like medications like trazodone, mirtazapine, melatonin that are helpful for sleep. And then there are some medications that are more helpful for mood symptoms that are mainly antidepressants. But there are now medications that we have to slow down the progression of the disease. And as Irina mentioned, they are called like anti-amyloids. And the purpose is to take the amyloid outside of the brain. And these medications are only for patients with Alzheimer's disease. And that's why we need to confirm whether there is amyloid in the brain. And there are two ways to check for that. One is through the spinal tap, and one is the PET scan of the brain. And then if that's the case, then, and there are other eligibility criteria as well. If someone meets those criteria, then they can go on these medications. But these are unfortunately infusions, so they're not as easy to administer as the pills. And lecanemab or Leqembi, which is the like the one that came out first, it was not too long ago, it came out in 2023. And it is every 2-week or bi-weekly infusion. And then the newer one, which is the donanemab or Kinsella, is monthly infusion. And then as some might have heard about the side effects or the serious side effects, they're not very common, but they are serious. One is brain bleed and one is brain swelling, in addition to the possible infusion-related reactions. But those medications, again, are supposed to help slow down the progression of the disease. They're not 100% effective. Again, patients still might decline, but at a slower rate. So they're not supposed to improve the symptoms or reverse the symptoms. They're just supposed to slow it down.
And before we dive a little bit more into the clinical trials and what's on the future, to give everybody a really happy note, end on a happy note before dinner, or dinner on the West Coast, I guess, and later in the evening on the East Coast. I wanted to ask Layla, so you talked a little bit about supplements, that when you go through your diagnosis that you ask about supplements. Any supplements that, and I know supplements, but everybody asks it because of those Prevagen commercials, but any supplements that could help with the progression of Alzheimer's, in your opinion?
In my opinion, it might differ from others, is that generally the supplements are not shown to have, the ones that I know of are not shown to have much of a benefit, like Prevagen, or vitamin E we used to recommend, but just seems like the information isn't there that helps support it as much. But things that are high in antioxidants in your diet are generally recommended. So eating berries, citrus fruit, good fats like healthy nuts, almonds, walnuts. Even the fish oil is a little bit, I think it could be beneficial, but more from the diet, it seems like that's to be the most beneficial. But there was a study looking at multivitamins where people who are taking multivitamins might have a little bit more of a less dementia risk in the long run. So I think it mainly just comes from diet, really, making sure that you're hitting all the vitamins that you need. So if you're low in vitamins, then supplementing it in that regard. But maybe other people have additional information.
Well, I'm sure Irina would agree with you on the food thing, but it's so interesting because at an event we did on the East Coast, that's exactly what the panel said. If you're getting good vitamin B and stuff through your food, probably don't take high doses of it through a pill. But they also said a multivitamin might be okay. Any other thoughts on that, Travis, Irina, or Golnaz?
I want to say, I know that they have very convincing commercials. They have very high marketing budgets. They're a trillion-dollar industry, but unfortunately, the evidence doesn't really support their use unless, for example, we check a vitamin B12 level and we see that your level is low, then we will recommend supplementation. But barring that kind of scenario, save your money.
Yeah. And also someone's asking about lithium, which has been like a question that has like been flooding all of our inboxes. I will just say there was a study that came out that was about lithium, but it was in mice, and genetically engineered mice. They gave them this like specific form of lithium orotate, and the mice did better on some of their mouse tasks. So it hasn't been replicated in humans yet. I mean, hopefully they do those larger studies. I mean, sure, though, I have plenty of patients, though, who, I mean, people want to try anything, right? And I get that impulse. And I have a lot of people who just have gone out and done it. The lithium that we usually use in medicine, we're using doses of like 300, 400 milligrams for like bipolar. And these doses that are available over the counter are like 5. I mean, so I do think it's safe. I don't think there's really data to support its use. I mean, I have people taking it. No one's really told me it's been this amazing thing, but we have no human studies. It was done in mice, and that the mouse study was a really interesting study with lithium. I do just want to make also a point about just to like also emphasize, I mean, yes, there are pills for Alzheimer's disease that can help symptoms, like Golnaz was discussing and laying out. And there are these newer anti-amyloid infusions, I mean, specifically for Alzheimer's disease, which are not a cure by any stretch, but are really the first thing we've ever had which can, affect the trajectory of the disease at all. And so it's been very exciting while these drugs aren't the cure, but to at least have something now that can slow down the trajectory. And just what's really important with these medications is that we know that the earlier we can intervene and start them, the greater slowing we see in people. And so it's really important just as a message to get out there, like the earliest whiff of any sort of cognitive concern, if we can catch people at that earliest stage, we can really do a lot to slow down future decline. And so early diagnosis is really critical in this area of newer therapies because we know as people get more and more advanced, more and more pathology builds up in the brain, these infusions, which remove the amyloid, don't work as well. And so we're trying to catch people as early as possible. And the other really exciting thing I just want to say, and I guess as we transition more to talking about other trials, we are looking at whether removal of amyloid from someone's brain before people have symptoms can prevent Alzheimer's disease altogether. And there are trials ongoing right now looking at that. There's the AHEAD study. There's also the Trail Runner, I think, I forget the exact name, from Eli Lilly doing a similar thing. And so we're looking at this, and these trials will probably read out in the next few years. But just to get a sense of what's on the horizon, it's possible that we're going to be trying to identify amyloid plaque deposition in people before they even have symptoms to try to prevent Alzheimer's disease, hopefully altogether. Or at least that's the major hope of the field. That's where things are going. And we'll have some more data on that hopefully very soon. But it's all about early diagnosis from a treatment perspective, also just for long-term planning, very important. But I just want to drive home the message of really early diagnosis is critical. If you or your loved one is concerned, like please get an evaluation to see if something's going on.
So if you had a crystal ball, would you say that down the road, you know how you have colonoscopy and you have maybe you go to a cardiologist or you have mammograms starting at a certain age that you're going to have like a brain diagnosis
Yeah.
at an early age? And
Yes.
another thing is, does plaque do any good? Like you remove my plaque, am I going to be the same?
We don't
No.
see.
No.
I don't think plaque is doing anything beneficial for you.
Okay.
There are many. We don't really know why it deposits in the first place. I mean, there's some ideas about clearance and all this, but in a lot of the time we don't know why it starts. But removing it, and when we remove it from people in these new infusions, like those people aren't getting worse. So if it was doing something beneficial for them, I would imagine that people would be like getting worse faster. If removal of the amyloid, if the amyloid was doing something positive, if that makes any sense.
No,
Um,
that makes sense because I know it starts developing, when you're in your 30s. So,
And yeah. And when you look at plaque often in a microscope, there's lots of angry stuff usually around it in people's brains when we study it at autopsy. It doesn't seem like it's just sitting there um, a lot of the time inert, doing nothing. It's like irritable to the brain. And it's probably not a good thing that it's there, like mucking with brain function. Um, but trials are really there's a lot of interesting trials happening. I personally think that the trials, because Alzheimer's disease is really these two proteins. It's this amyloid plaque protein, which we've talked about a lot, but it's also this protein called tau. We know from looking at these large studies, amyloid deposits first, tau comes on and starts depositing later. And we think it's really the tau that's more directly related to injury and symptoms and damage. And we've got things for amyloid, but we really need things for tau. And there's a lot of interesting tau trials happening currently. A lot of tau trials that are being studied. So hopefully we have some more, tau therapies coming out sometime soon.
I just think that that is so exciting. And Monica Moore just signed on, who is actually one of our panelists next week. And she reminded me to tell the audience, if you registered for this, you're registered for that. And that will be more of the clinical social worker, caregiver aspect of how we can be really helpful from a home, or even as an advocate as your loved one progresses with a type of dementia. So same time next week, I expect to see all of you here that have been so incredibly great in the Q&A. But one question came on, and it's from an anonymous attendee, but I'm sure that his or her question is in the minds of many people here. Okay, I've got MCI and it's progressing and I'm getting worse and worse and I can't get in to see a neurologist for 6 months. Any suggestions from the team here?
You can send them my way.
Oh,
Send
there
me an
you
email.
go.
Or anyone else. Yes, it just sometimes it takes a little bit of persistency. Sometimes there's an opening, or you could go through the general practitioner. You can go to the primary care physician to see if they can help to get you in, or general neurology. But feel free to reach out to me if you need help. Sometimes there's just openings in the schedule that come up. So
I
Yeah,
think
it's very hard. Like there are not enough of us who do this kind of work. There are not enough neurologists, depending on your area. So it is hard, and I totally acknowledge that. It's really just about persistence. If you're like hitting a roadblock, and just keep calling, because like Layla said, sometimes somebody doesn't show up to a visit one day. We have this open slot randomly. Like maybe that you just happen to call on the day where there's this new opening. But if you're not getting like something within your health system, you could try going outside of your health system, some like where else. There's many health systems in any given area. Okay, depending on where you are, but you could try a different health system and see if it's more successful there. But really, it comes down to persistence. But I hear you. It's oftentimes hard to get in, but once you're in, it's great. But getting in can be hard to start with. It's true.
you just have to be an advocate, but go ahead, Irina.
Oh, I was just going to quickly say two things, which is, we are not the only ones who can prescribe these types of medications. So your primary care doctor may be able to get the ball rolling with some of the medications we've been talking about. If you're suffering from insomnia, if you're depressed, they can get those medications started. But secondly, you can ask to be placed on a wait list so that if a sooner appointment comes up, then they can give you a call and let you know.
And I got to tell you, I just did a webinar last week. Everybody should go on a Kensington website with Dr. Sarah Kim, who is at Cedars-Sinai and is a partner with GOLNAD. And she is amazing, and she is a neuropsychiatrist. And the question came in, how do I find a neuropsychiatrist? And yes, they can start the ball rolling. Travis is answering the question, but I should probably ask one of you that can maybe do that 3-hour test or at least get the ball rolling. Is that correct?
Yeah, it's neuropsychologist. Just I know it's so silly, but it's not neuropsychiatrist, it's neuropsychologist. So they're not MDs, they're usually PhDs. But just when you're typing it in Google, like that will make a difference. So it's neuropsychology. And I would honestly Google it. I don't know. There's probably some sort of neuropsychology association you can look at and see who's nearby. Um, but just Google like neuropsychologists near me and see what comes up. Usually they're PhDs.
But
And go ahead.
Sorry, I was quickly going to say primary care doctors can directly refer to neuropsychologists. So you don't have to wait to see a cognitive neurologist to see a neuropsychologist.
So that's great information for the audience today. And I cannot thank you guys enough for your heart, and your hearts are as big as your heads. And I just am so appreciative. And the audience is giving us unbelievable feedback. So thank you so much. And we will send a follow-up email to everybody with a copy of the presentation. And thank you for everybody. Thank you. Have a nice evening and or afternoon. Thank you.